How to treat scoliosis in adults. Unfortunately, scoliosis can affect all ages. Now, the first classification when we look at scoliosis, even beyond severity, is age of patient, because the age of patient is really what determines how we actually treat a patient, and what we're concerned about risks of progression and the associated causation. Now, when we look at infantile scoliosis, and these are babies that are born with scoliosis, this is what we call congenital scoliosis, and this is when the patient has actually developed an abnormal vertebra in utero and is called a hemivertebra, and they're born with something called congenital scoliosis. Now, sometimes it's diagnosed at birth, but sometimes it's not diagnosed later on into life. Infants can develop the scoliosis, and this is called infantile scoliosis, and this is typically when the diagnosis is made between 6 and 2 years of age or 3 years of age. Juvenile scoliosis is typically when the diagnosis is made between 3 and 11 years of age or so, or pre-puberty. So between 3 and pre-puberty, this is when we call patients that have been diagnosed with juvenile scoliosis. Adolescent scoliosis is between 10 and 18, or 10 and skeletal maturity. Now, skeletal maturity for some patients is 14, others it's 19 or 20, but it's between 10 and skeletal maturity. And then anything, once a patient is fully skeletally mature, it's considered adult scoliosis. Now, when we look at scoliosis, by far the most common type is something called idiopathic scoliosis. And this is the largest group. And this is by far about 80% of all the patients that exist that are ever diagnosed with scoliosis. So despite of the age, whether it be infantile, juvenile, adolescent, adult scoliosis, idiopathic scoliosis is by far the most common, and this is when we say we don't know what's causing it. It's unknown. There's no single cause that can be associated with the causation or the development of scoliosis for that patient. This is when there's no other conditions present and the patient only has scoliosis. The remaining 20% do have associated causes. Like I mentioned, congenital scoliosis is when the patient's physically truly born with scoliosis, and that's the abnormal vertebra in the spine that we call a hemivertebra. And then the other 15% or so, this is about 20% of all cases, is either neuromuscular or degenerative. Neuromuscular cases is when a patient has a neuromuscular syndrome or problem and they develop scoliosis as well. Neuromuscular conditions are things like cerebral palsy, Marfan syndrome, Ehlers-Danlos syndrome, neurofibromatosis. It's something that affects the nerve system, something that either affects the connective tissue causing contractures or laxities, which can be associated with the causation. These are typically diagnosed in adolescent stage, but sometimes they go undiagnosed and they're diagnosed again later in the adult stage. And then the last type we like to look at is something called degenerative scoliosis, which is also called de novo scoliosis. Degenerative scoliosis, when it actually occurs only in adults, it doesn't occur in children. Now, symptoms definitely differ between children and adults. When we look at the symptoms associated with scoliosis, children it's only postural deviation. We typically see postural misalignment, shoulder misalignment. We see ribs out of alignment. We see a postural problem. And it's normally the posture problem that brings on the evaluation, which eventually brings on the x-ray, which brings on the diagnosis of scoliosis. Now, if the posture problem isn't noted, a lot of patients will go undiagnosed in the adolescent stage, even though they have scoliosis, because the postural deviation doesn't become severe enough, or they never get evaluated properly by somebody looking at their posture closely to see if there is any asymmetry in their posture. In children, there is no normal asymmetrical postural finding, meaning if there is asymmetry from one side to the other, there is never a case that's considered normal, especially if it's relatively significant. The main symptom in adults is not posture. It's back pain, and it's pain, typically low back pain radiating to the extremities. The most common is left low back with left leg pain, right upper back pain, right neck and shoulder pain, because the most common scoliosis is a left lumbar, right thoracic. So those are the most common, but it's by no means limited to that. It's normally going to affect the area of the scoliosis where it's located and to the side that the curve goes to. Now, the reason why scoliosis causes pain in adult patients and not in children is because children are growing, and when they're growing and their curve is worsening, the growth and the lengthening counteracts any type of compressive forces, and the body's adapting to the curve. So the person is growing while they're developing the curve. The body has the ability to adapt to it and doesn't cause a lot of pain. Unfortunately, in adult patients, it's the exact opposite. The scoliosis becomes compressive as a result of gravity. This compression leads to pain to the nerve tissues and muscles and fibers, and the body doesn't have the ability to adapt adapt to it as quickly and as well as while they're growing. So therefore, that's why it causes pain in the adult cases. So sometimes patients can progress more in the adolescent stage, maybe 50 or 60 degrees, and have no pain. Progress 5 degrees in the adult form, and that 5 degrees will lead to pain. So it's not relative to how big your curve is if you're going to have pain in the adult stage. It's relative to how much you progress in the adult stage. So you can have two patients at, say, 40 years old, and somebody has a 40-degree curve and another person has 20. The 40-degree curve, they grew with 40 degrees and maintained 40 degrees their whole life, more likely not going to develop pain, where if somebody had developed a 10-degree curve as an adolescent, then progressed 10 degrees to 20 degrees in the adult, that 10 degrees will cause pain, even though their curve is smaller. So when we look at this, we understand that the most common type of scoliosis is by far idiopathic scoliosis. So therefore, since the most common type is idiopathic scoliosis, it's adolescent idiopathic scoliosis. The most common type in the adult is adolescent scoliosis in the adult form that's now progressing, were either diagnosed or undiagnosed. I see many patients that come to the clinic and they found out they had scoliosis in the adult form, even though we can tell by the x-rays that they had adolescent scoliosis, but they were just never diagnosed. In many cases, the symptoms of adolescent idiopathic scoliosis is mild. Mild meaning it doesn't cause pain. It doesn't cause malfunction. They can participate in sports and activities like all other kids. So therefore, it's considered mild, meaning it doesn't impact their daily life. And unfortunately, since it's not impacting their daily life, and they only have posture issues, a lot of times the kids won't talk to their parents about it. The parents may think it's not a big deal, and it gets untreated or undiagnosed, and then they become in the adult, and now the curves start to progress, and they compress, and they lead to pain, and now they say, oh, it's because of your scoliosis. So therefore, we understand that these idiopathic adolescent scoliosis cases become more challenging to treat in the adult form because the curves become more stiff and the curves are also bigger. Now, the second type of scoliosis in the adult form is something called adult degenerative scoliosis. And normally this is diagnosed at the age 50 years and plus. Definitely more common in women than it is in men. Men, it tends to happen a little bit later, around 60 or so years of age. And this is a result of degenerative spinal changes. Now, a lot of times patients will say, or doctors will say, oh, you're just having normal degeneration of the spine, and that's why you're developing this curvature, and they will say, don't even worry about it. Well, that's not necessarily true, because when we look at degenerative scoliosis, we see that the area that has the scoliosis, and that area of degeneration is way more severe than the rest of the spine. If it was a systemic spinal degeneration occurring through the entire spine, you'll see equal levels occurring through the entire area. But right there in the area of where the scoliosis is developing, you see excessive degeneration. And what this tells us is that something happened younger in life, in your 20s or 30s, that caused a shift. And this shift remained uncorrected. And unlike an unaligned car, the longer this stays out of alignment, the more it degenerates faster. It accelerates the degenerative changes in this area, which can lead to a degenerative scoliosis. This, again, is most common in the lumbar area. And in this area, it's pretty equal. We see right and left changes. So it's not only left side, but it can be left or right, but it's degenerative. Now, regardless of it being adolescent idiopathic scoliosis in the adult form or degenerative scoliosis occurring in the adult now developing, the biggest group of patients with scoliosis is adults. It's not children, even though we think about kids having scoliosis, not adults, but the largest group is adult patients, because you have all the adult onset cases, and then you have all the kids that were not diagnosed and now find it in the adult form, and then you still have all the kids that were diagnosed that still have it in the adult form. So the largest group, in fact, it's directly correlated as the patient age group increases by decade, the percentage of patients with scoliosis also increases. So we think somewhere adolescent cases, it's somewhere around 5% or so of cases of kids have scoliosis. Where we look at patients that are in the age group of 60 plus, they say 30 to 40% of patients could have some type of scoliosis. So treatment definitely differs regardless whether you're dealing with a child or an adult. Now, whether it's degenerative or whether it's adolescent scoliosis progressing in the adult, we definitely know that the progressive nature of scoliosis starts off slow in the adult form and it picks up speed as they get older. Where in adolescent, it progresses rapidly during growth. So it's very unpredictable. We don't know how much is going to progress, but it's purely dependent upon growth spurts during that time. In adult form, it's also, we don't know exactly what's happening, or how much it's going to progress, but it will slowly increase no matter what size the curve is. And as it gains progression, or as it gains size, it starts progressing faster. So since adults are no longer growing, we have more time to make influence on the size of curve, but the older the patient, the more difficult it is to reduce the curve, and the more likely it is to cause problems. So we always recommend treating curves as soon as possible. In addition, as the curve becomes bigger, it tends to cause more pain. So therefore, pain management is normally not common in children, but it's definitely common in the adult patients, because that's why they're normally coming in. It's because they're experiencing pain and they're concerned about the pain it's going to lead to, and if it continues to get worse, what's going to happen. In adolescence, we're trying to reduce curves below surgical threshold, so therefore they don't have to face the decision of surgery. Where in adult patients, a lot of times surgery may not even be an option because their curves have gotten so severe and surgery is so invasive for adult patients, they may not even be able to recover from the surgery. So normally we're just dealing with trying to slow down the progressive nature, reduce the curve, and manage function over the rest of their life. So even though curve reductions are available in both stages, in adolescent or adult cases, we have much different expectations and much different goals, because we're trying to normally improve pain while reducing the curve, right? So we're trying to do both things at the same time. So in adult patients, we like conservative treatment, and because of the main reason is surgery tends to be a very invasive option for adult patients, and especially as patients get older. So normally, when we look at patients with scoliosis in my clinic, I normally are treating patients that are adolescents that are rapidly progressing and they're trying to stop their curves from worsening. But normally as young adults, most patients get by just doing what they're doing, so I normally don't see them, even though this is the best adult patient, is a young adult that has a very flexible curve, that the curve isn't stiff or degenerated yet. But normally these patients I don't treat. It's normally not till 40 or 50 years of age is where the pain and problems become more significant, and the things that they were doing not becoming nearly as effective, and then normally they seek out treatment. At this stage, typically there's stiffness associated with the scoliosis, there's degeneration, there's disc herniation, there's muscle atrophy and weakness in certain areas, and normally there's been lots of postural changes and associated things that have been going on. So therefore, just trying to do a little bit of exercise to help rehabilitate this person's scoliosis doesn't produce a result. And they get very frustrated because what other people are doing for back pain is working for them, but it's not working for the scoliosis patient, because the underlying cause is the progressive scoliosis. So even though we like conservative treatment for adult patients, it must be scoliosis specific. And the scoliosis specific is normally a multimodal treatment option that includes many different things. Chiropractic care, of course, being at the core, but we have therapy, we have rehabilitation, we have corrective bracing, we have home therapy, and all these things must be done at a structural level, meaning we're not just trying to strengthen muscles, we're not just trying to increase range of motion, we're not just trying to, reduce the pain, we're trying to change the shape of the curvature and allow the body to stabilize this new shape, so therefore the person can have long-lasting results as the curve actually gets reduced. And then we have to hold that reduction down for a period of time so the body doesn't rebound back into this specific position. So we use this with using different combinations of therapies, different types of corrective bracing, and different types of rehabilitation, and different types of chiropractic. And all this is done is it's coordinated in a very specific way so the patient can actually respond appropriately. So even though we think of scoliosis being more commonly diagnosed in children, by far the largest patient population with scoliosis is adults. And regardless of age, the best time to treat patients is always sooner. So I always say the younger the patient, the smaller the curve, the better results, the more we're going to preserve, the better quality of life that can be improved. So for every adult that's listening to this video right now, you're never going to be younger than you are right now, and your curve is never going to be smaller than it is right now. So therefore, treating it sooner is always better. But the good news about adult patients, they're normally not progressing rapidly, so you have some time to figure out what's the best thing for you, but you normally don't want to be waiting 5, 10, 15 years to treat your scoliosis. You definitely want to be treating it sooner than later, because the sooner you treat it, the more likely you are to have a positive outcome. Thanks for watching. I hope you found this information helpful. If you'd like to hear about other topics and information on scoliosis, type in the comments below and let us know. And finally, subscribe and hit the bell icon to be notified of when we publish content. Thanks.